Good morning and good afternoon. I'm Selena Shawkin. I'm the Executive Director of Together for Health, which is a partnership of organizations working to raise awareness of cervical cancer, to increase resources to fight the disease, and to promote innovation and adoption of effective programs and technologies to fight cervical cancer. We have an exciting webinar today, which is part of our fall webinar series. Today's webinar focuses on evidence and best practices for the integration of family planning and cervical cancer prevention. PSI is co-sponsoring this webinar with us. The webinar follows the conclusion of the International Conference on Population and Development, ICPD Plus 25. So it's a perfect time to talk about ways to integrate these essential aspects of women's health. A few housekeeping notes before we get started. All participants to the webinar are on mute. I'd like to call your attention to the Q&A icon. It should be at the bottom of your screen. You can submit your questions using that tool. I'll track the questions as they're submitted, and I will ask them to the speakers. There will be time for Q&A at the end of the webinar. If you have to drop off early for any reason, we will post the complete webinar on our website, togetherforhealth.org, within the next few days. Now let's get started. Our first presenter is Ravina Chowdhury from Marie Stopes International, MSI. Ravina is a sexual and reproductive health expert who has worked in this field for 20 years. Currently, she heads up MSI's cervical cancer prevention program and manages the CIF donor portfolio. She's led the establishment and integration of cervical cancer prevention within MSI's existing programs and the implementation of new diagnostic technologies. Ravina will be speaking about why integration of family planning and cervical cancer services, evidence from operational research. Ravina?
Hello. Thank you, Selena. Selena, can you hear me?
Yes.
Okay, excellent. Thank you so much, Selena, for that introduction. And the integration of family planning and cervical cancer services is something that's very close to my heart. So I'm really delighted to be on this webinar today. For those of you who don't know Marie Stopes International, we're a sexual and reproductive health organization with a presence in 37 countries across the world. MSI has a cervical cancer prevention program in about 20 countries. We do screening, treatment with preventative therapy. We have a small, we've run a small DNA pilot, and we also have a nascent HPV vaccines program. In 2012, we were invited by the Gates Foundation to form a consortium along with PSI and IPPF to integrate cervical cancer screening and cryotherapy with family planning. So in this presentation, I'm going to cover three topics broadly. I'm going to just very quickly run through our integration model. I know that my colleague Heather from PSI is going to talk about this a bit more. I'm going to share the outcomes of our integration and give you a summary of the key successes and considerations. So what I think integration means different things to different people. And I just want to say that this is one model of integration. It's not certainly the only one, but I think the lessons from this apply to many other models of integration. So what we've tried to achieve here, I'm just trying to say to you how we defined integration. What we tried to achieve was to give access to women to high quality family planning and cervical cancer screening and cryotherapy in a one-stop shop with the right information that they needed to make for an informed choice for family planning and to take up cryotherapy should they need to. Slide. So we implemented several different models of integration. We implemented these in our static centers through outreach and also through our social franchisees. So how did we integrate? We firstly worked with the ministries of health to get the right approvals in place. We conducted training for our own providers, but at times also for Ministry of Health providers. We set up an international and local procurement system. to take into account all the new supplies that we needed for integrated service delivery. We conducted demand generation that was specifically for cervical cancer prevention. And importantly, we updated our MIS data collection capacity to make sure that we are able to track how many of our clients actually get treated. And we delivered these services both through routine service delivery, like walk-in services in clinics, but also through special events where we would have a one-day campaign where women could come in for a screening and get a family planning service as well. Next slide. So this slide just gives you an idea of what it was, what were the considerations and what was the impact of integrating into different channels. So our centers these are sort of mostly in urban areas. They're static centers. They're owned by MSI. And it was fairly straightforward to integrate into our centers. It was easy for us to make sure that cryotherapy was available where we were screening. We found that as a result of this integration, we were getting more clients coming in, which was good for the sustainability of the clinic. And also we found that it improved the productivity of our service providers. On outreach, it was a very different scenario. Now, outreaches we hold mostly in urban areas. There are different outreach models, but typically you will have a large vehicle traveling out with anything from 1 to 5 providers providing integrated services. And this helps us to actually go out into the countryside and meet the needs of women who wouldn't normally have access to services. So this really does, go into areas, accesses women who will not have normally access to any kind of services, let alone screening. So the great lesson over here was that we are able to provide cryotherapy. It's a little complicated to provide cryotherapy with a sort of a mobile team, but the main lesson learned was that even though it's difficult, it's not impossible. We also found that the client flow on our outreaches increased a lot. We were getting sometimes, instead of getting 30 to 40 clients as we normally do, we were getting around 200 clients. So this was again something that we needed to manage very carefully. And there was a very nice model that we implemented in Tanzania, where we had a 3-wheeler Bajaji going out with a midwife and a cryotherapy machine providing a single visit approach. This was done in peri-urban areas and was a very nice cost-effective way of screening up to 50 women in a day. The experience with social franchisees, and this again, I know my colleague from PSI, Heather, is going to talk more about, but we found, that sometimes it was difficult for social franchisees to get the treatment piece right. And certainly for MSI, we felt it was best to focus on our sort of high-performing, social franchisees with a high client flow, and once we targeted these star social franchisees, if you like, this was an attractive value add to the package that we were offering to our social franchisees. Screen. Thank you. So I'm going to go through some of the successes of our integration efforts, and the first success is the fact that we, as a consortium, managed to screen 2.1 million women and provide cryotherapy to around 34,000 women. And we ended the initiative with a 90% treatment rate. Now, considering that, the whole model was to leverage family planning platforms and use these to also provide cervical cancer screening and cryotherapy. We feel that this was a great success. Slide. So the second success was that this integration brought in different clients. Slide, please. And what we found was that our cervical cancer clients tended to be a bit older than our normal clients. And that they were higher parity clients than our typical family planning safe abortion clients. Many of them have already reached their desired family size, and therefore, they did have an unmet need for long-acting reversible contraception. It's also worth mentioning that cervical cancer screening clients had a higher than average prevalence of HIV, and also that most of them were first-time screens. So, slide please. So the third success was that this integration effort brought in new clients into our centers, and most of these were first-time screens. Slides. So it's worth noting here that the family planning clients who received a cervical cancer screen were 132% more likely to be a new client, and 90% of our clients who came in for screening were first-time screens. Slide, please. So the fourth success was that once, clearly we were getting more women through the door. And the success was that once these women came in, they tended to take up other services. Slide, please. So what other services did they take up? We found that 68% of clients said that their primary reason for visiting the facility that day was to get screened. And once they were in there, you can see on this table that they took up a large number of them took up another service. About 77% of them took up another service. And as you can see, of these, the largest uptake, almost 35%, was of LARCs, long-acting reversible contraception. Almost 25% took up family planning counseling. And then the others took up a range of other services, ranging from HIV testing to STI treatment, and even long-term methods like tubal ligation. Slide, please. So the fifth success was the fact that our screening clients were more likely to accept a long-acting method. Slide, please. And this slide shows us data for 3 months before we integrated services, 3 quarters before we integrated services, and then 3 quarters after we integrated services. This contains data from OPS research that we conducted across MSI, PSI, and IPPF. And as you can see, there is a very marked increase both in implants and IUDs as soon as we integrate cervical cancer into the cervix mix. Slide, please. So the next success is that there was an increase in the overall volume of family planning services. Slide, please. And this slide compares data. This is sort of routine CYP data from 10 clinics in Tanzania. And we compare here months where we had a special cervical cancer event that lasted for 3 days and months where we didn't have this. And we found that the average CYPs in months where we did conduct a cervical cancer screening campaign, we had 3 times as many CYPs compared to months where we didn't do any campaign. Slide, please. So I'm sorry, this is a little bit of a dense slide, but I'll go through this because, as we went along, we learned various operational lessons. The first one was that, screening is a great art. As my medical director at MSI says, it's more an art than a science, and that the service providers really require a huge amount of practice and skills in order to conduct high quality screenings. The second lesson was that we need to have strong oversight over supplies. So, we need to provide, if we're doing cryotherapy, we need to procure CO2 gas. If we are doing screenings, we need to have acetic acid. So we need to make sure that we have the right supplies. Otherwise, it impacts on the quality of your program. The other thing we found was that it's not sufficient to do a one-off training, and that a long period of mentorship is required to ensure that service providers are actually proficient to provide screenings and also to become master trainers. We experienced very heavy client loads after we integrated services. So, we learned, it took us a few weeks of service delivery to figure out how best to manage the client flow, and the fact that we need to triage very carefully to make sure that clients don't have long waiting times. As far as demand generation is concerned, we realized that we need specific demand generation for cervical cancer screening, because we are targeting women who are slightly older than our standard family planning clients. So, this needs to be taken into account while doing the demand generation. And I think importantly, from a public health perspective, we found that it's really important to provide a single visit approach. We had instances where some of our providers were doing many screenings but no treatment. And actually, there is no public health benefit to simply screening lots of women. So the public health benefit comes from being able to identify lesions correctly and treating women. So it's extremely important to provide cryotherapy or thermal ablation where you are providing a screening service. And finally, it's important to have a discussion with women about their comprehensive SRH needs. And this really improves the quality of the dialogue. And when you have these conversations, we find that women are able to talk about all their fears and all the concerns they may have about an IUD. And if you have a comprehensive discussion, it's far more useful for the women we're trying to serve. Slide, please. I think this is my last slide, and this has the key takeaways and considerations. And I think the most important takeaway for us was that it's absolutely feasible operationally to integrate cervical cancer prevention with family planning. And it serves many different purposes. I think importantly, it increases the uptake of all services in the package. It reduces the stigma that may be there around the provision of family planning services. And it certainly improves the dialogue that you have with a woman, since you're looking at her holistic needs and you're adopting a life cycle approach. And this really improves our interaction with our clients. And I think the important thing to remember is it has several benefits. The service integration has several benefits, but we must be careful as we integrate. It must be done very carefully and skillfully. There's several considerations. We need to make sure that referral networks are in place for higher level treatment. We need to keep in mind that it's important to have some political support. We found in our experience, MPs are very quick to sign up and they want to support this cause, and then as soon as they realize they get pushback from their constituents that there's no treatment available, suddenly that political support disappears and they don't want to be associated with with cervical cancer. So I think it's just important to manage that carefully in country. And also, integration costs money. It becomes, there are savings that are made through integrated service delivery, but it requires a certain investment to set it up correctly. And that it requires, ministries of health and private NGOs to enhance their technical capacity to be able to deliver integrated services. And both the technical capacity and the service delivery capacity need to be expanded in order to deliver these integrated services. So thank you very much for listening. That's my lot. I know that Selena is moderating the Q&A, and that's going to take place later on. So I will stop there. Thank you very much.
Thank you so much, Ravina, for that excellent presentation. We do just have a couple of minutes, so I'm going to ask you a couple of follow-up questions before we move on to the next presentation. We had a couple of questions about your program. One question was about the screening method that you are using, and another question was whether or not you have used thermal ablation to treat any of the women with precancers. The writer noted that they had found it easier to use than cryotherapy.
Yeah, these are great questions, because I think what we haven't covered in this presentation is the fact that we're moving very rapidly towards new technologies, and what we used was VIA. In some cases VILI, but mostly VIA, visual inspection. And the reason why, if we were to do it again today, we would not use VIA, because I think it's broadly acknowledged that this is not a very, it's not a very accurate screening technology. So, we are now moving on to different, newer, more, much smarter screening technologies. So we used VIA because this is what was available then. So that's the first question. Now, thermal ablation, yes, absolutely. For those who are not familiar with thermal ablation, this significantly reduces the time of treatment. So, for MSI, the treatment time is roughly 17 minutes for cryotherapy. And for thermal ablation, it's a much shorter treatment. The treatment itself is, I think, 1 minute, but, including the insertion of the speculum and so on, it takes a maximum of 5 or 6 minutes. And it doesn't require you to carry gas. So certainly, across the board, it's good to use, but especially in mobile settings, it's very useful. Did we use this? No, we didn't use this, because as you are probably aware, this was only approved by WHO a few weeks ago, maybe a few months ago. So again, keeping in mind that we started our integration efforts in 2012, so none of these new technologies were available to us then. So, we simply used VIA and cryotherapy. Having said that, we did run an HPV DNA testing pilot with PSI and IPPF, and I think we achieved really good results with that. But I think the big thing at that time was the cost. So we're looking forward to having cheaper screening technologies available soon, so that we can integrate those within our platforms.
Great, thank you. And I just wanted to call people's attention to the Q&A box down at the bottom of the screen to ask your questions, and we'll have time to ask more questions at the end of the webinar. But I want to move on now, and thank you very much, Ravina. Our second speaker is Eva Lathrop from PSI. Dr. Lathrop is the medical director for PSI. She oversees service delivery portfolio that spans over 30 countries and focuses on sexual and reproductive health, abortion, and cervical cancer work. She also works to evolve PSI's quality approach within primary healthcare. Dr. Lathrop's experience prior to PSI spans 20 years of experience in clinical care, teaching, research, and practice in global reproductive health. And most recently, she served as Associate Professor of Gynecology and Obstetrics in Global Health at Emory University Schools of Medicine and Public Health. And she is going to speak about how to integrate family planning and cervical cancer services, a review of key operational learning. Eva?
Thanks, Selena. Good morning, everybody. Good afternoon. Selena, just let me know that you can hear me okay?
I can, thank you.
Fantastic. Ravina, thank you for setting the stage and making the strong evidence-based case for integration by sharing MSI's experience. I personally learned quite a lot, so thank you again. And I'll take my time to review PSI's key operational learnings on integration and present to you how you might go about designing an integration program from our lessons learned. Next slide. So the basic premise of integration, this is review for everybody probably, but of any service in SRH, is that we can holistically respond to the needs of girls and women. We can be more efficient and offer more value and increase impact. So by integrating cervical cancer screening and prevention therapies into our SRH programs, we can better meet women's health needs across the life cycle and increase our impact. Next slide. And PSI offers integrated programs already across the SRH spectrum in HIV and STIs, voluntary family planning, cervical cancer prevention, and beyond. And today I'll outline the work that we've done to date in integration of family planning and cervical cancer programming across our global network. Next slide. So this slide is a bit on the busy side, but I'll go over it with you. On the left, these statistics show the cervical cancer screen and treat services provided since 2012 in our global network. There are 19 countries total, and by now we've probably screened closer to 1.5 million women through these programs rather than the 1.3 I have listed here, and over 23,000 women or more have been offered treatment with cryotherapy or LEAP procedures. The information on the right side of the slide shows the CYPs and users reached for voluntary family planning in 2018. In 2018, PSI reached 10.7 million users with modern contraception and provided 2.3 million HIV self-test kits. We provided 17.7 million CYPs, 7 million of those came from LARCs, or the implants and IUDs, 6 million from condoms, 4 million from the short-term methods, and then less than 1 million from permanent methods. I included this because I wanted to demonstrate the exceptional reach that we have in the realm of family planning in many of the countries where we probably need to be doing cervical cancer programming, but aren't doing that yet. Part of that may be that we're not exactly leveraging to the extent that we could the depth and breadth of our collaborations and programming that we've done, and we recognize this as a learning point and see this as an opportunity to do more. We have such reach as an organization on the family planning side. We need to do more to balance the services through integration. This is a priority for us, and I think we're poised to offer more cervix cancer screening services and prevention therapies, and I think integration offers, at least for us, the best operational platform to do so. Next slide. So I think, as many of you know, PSI has a number of different service delivery settings and models. Some are static, and those are can be the private and public sector delivery, and some are in the community-based realm. I think it's important for people to understand the spectrum of channels through which we could consider an integration model by outlining the various service delivery settings that we may use at PSI. People do know us for our work in social franchising, and that is work that we do with over 10,000 independent health providers across our global network. We offer products and services with PSI support. Then for the clinical service delivery side, the quality assurance side, marketing and promotion. But we also work with different other variety of clinical models, including the public sector. So we may second a private provider to a public facility to support the public sector in both the training or direct service delivery realm. And then there are, again, the community-based service models, which can be either static or attached to a mobile clinic. So each of these settings can be used for integration but would require slightly different planning and preparation to serve clients efficiently. They can each offer multiple SRH services in a single visit, and I think that's the key. Next slide. So the next two slides are about preparation and planning from a policy and service delivery context. And I think in order to understand the policy context, we can look at the landscape through challenges, opportunities, and champions. So it would be important when you're starting to design an integration program or your program is starting to think about it, to know what the national protocols and plans already are in terms of integration or cervical cancer screening and prevention. Understand the role of domestic financing, the role of technology, what investments have been made or have been committed. It would be useful to map the health system and what services are provided where. Is there already any integration? And how is data captured at a national level? I think understanding the national context from an epidemiologic perspective, what's the current plan, the national plan, what commitments have been made for resources and staffing? Are there technical needs? And these are all integral questions we need to ask at the planning stages of integrated services. Getting this buy-in at the very early stages in the policy and planning level is key, I think, to success on the ground when you start to build your programs at the service delivery level. So I think it can sometimes feel like a heavy lift at the beginning to do this landscaping and mapping, but it pays off when you start to build your service delivery program. Because cancer and family planning resources may sit across different ministries and budgets, I think it's critically important to gain political support early and identify champions to do this work. So find your champions. I think we use that word a lot, but it's the right word, I think, in this instance. And I'll give an example of an instance in which PSI really found a champion team. This was in Tanzania when we were first proposing our plan to integrate VIA-based screening and cryotherapy into existing family planning programs. This was supported by the Bill and Melinda Gates Foundation. And one of the Ministry of Health teams pushed back a little bit to say, yes, we can, it would be great to integrate VIA and cryotherapy into these existing programs, but you can only do it if you offer women same-day cryotherapy. So if we couldn't do that and couldn't guarantee this provision, then this team was not interested in supporting the program. So they were very clear about setting a high bar for a high quality program that would serve women's needs. And having that clear directive from the Ministry of Health meant that at the outset, as a team, PSI moved a little bit slower, but in the end, we're able to build strong programs and had a much higher treatment rate than in other program countries where that provision wasn't really set in stone. So I think that's a good example of why we always need to find our champions. Next slide. Part of preparation and planning is also exploring what's in place in terms of broad service provision. Establishing a baseline understanding of the context of services before you start is obviously critically important in order to be ready for integrated service delivery. So in the realm of sexual and reproductive health services, some questions you may ask at the outset: what services are currently being provided to whom and by whom? How will integration affect existing client load? So Ravina gave a great example of when they started integrated services, all of a sudden their volume increased exponentially, and having a heads up about whether or not that could happen will help you plan your program. So it's critically important to do an analysis of client flow in a single service and then model how that might change in an integrated service for optimal use of physical space, of human resources, of costs, et cetera. It's also important to take a look at training needs. Look at the training needs among the different cadres, the clinical staff, your administrative staff, the QA teams, if you have a lab, community promoters, et cetera. So what skill sets are already there? What are you working with at baseline? Who needs to be trained? Who needs strengthening around training and best practices? There are very likely well-vetted master trainers in each country, probably in VIA, cryo, maybe thermoablation. And we need to make sure that we're doing our due diligence to understand who's already trained and trying to pull them into our program. Obviously, this isn't exclusive to cervical cancer work. I think this is the same for every service, but it's the right thing to do. It's a good time to remind ourselves that it's the right thing to do. It makes good sense to do things that way. And then the last bullet here is to identify technical working groups and professional bodies that may already exist. And I think in the realm of integration, we don't always have specific technical working groups. So we'll likely have to sit in a broader technical working group at the outset, whether it's family planning or a broader reproductive health group. But I think it's worth trying to get into those groups to bring folks together who are working on integration to share the body of knowledge and share those practical viewpoints within the country. Next slide. I think once there's a good understanding of the policy and service delivery context, it's time to start thinking about how to inform demand for integrated services as a critical step. A suggested start is to review what exists already in terms of SRH communication materials. Are there interpersonal communication materials that already exist? Can they be adapted for this work? Do you need to start from the beginning? Throughout this whole process of trying to develop messaging, it's critically important to seek regular client and provider feedback. What do people know already? What do they need to know? Where are the gaps? What are the favorite channels that people like to hear from? Is it radio? Is it community health workers? Is it on their telephones, et cetera? And then we need to figure out how to develop messages across the SRH spectrum and the life cycle. Consistently working with providers and clients on messaging is also an iterative process. So we may develop messages and have to test them and change them and tweak them throughout the lifetime, I think, of the programming. And I think it's important to acknowledge that there's not a perfect overlap in messaging on cervical cancer and family planning. I think Ravina mentioned when she was showing some of her data that the age and parity differences for the cervical people who are coming in to also have cervical cancer programming are different compared to the average family planning client. So there isn't a perfect overlap, but there is some overlap. And for example, in the differences in age groups. So it's important to navigate this tricky space. One of the things that PSI is doing in Mozambique under the PEER program is about to do an integrated family planning and cervix cancer journey map to really understand from both the supply and the demand side, how do we deliver more coherent and more seamless messaging across the health areas so that we can really reach and serve the women that we need to. Next slide. So after you've done all that, you may be ready now for service delivery. Once service delivery is launched, routine monitoring of client volumes, uptake, loss to follow-up, et cetera, is critically important. Again, the client volumes might increase dramatically, they might not, but you might see a sudden increase in volume and a real need to quickly adapt to that. So in order to do that, we have to review service volume. So ensuring that the services we're providing are still high quality. Take a look at method mix. Has it changed at all with the integration? Is voluntary family planning still voluntary? How have times changed, whether that's wait times, total clinic times, times per service, how quickly we can move people through in terms of client flow. What are the financial and opportunity costs that we predicted, and what are the ones that have cropped up and surprised us, and how do we adapt to that? And then is there a need for additional care beyond the primary level, and have we set up a referral system that is working, and how do we test that and constantly make sure that there haven't been gaps? And importantly, we always need to talk with consumers and providers regularly through a variety of methodologies, including, for example, client exit interviews. I think many people on the line have been engaged in client exit interviews. Focus group discussions and in-depth interviews is another methodology with clients and all frontline health workers. It's important, in terms of health workers, I think it's important to be sensitive to the burden that providers may face when we add a new service. And working with providers from the beginning to realistically understand their challenges will be helpful. We need to constantly track messaging and communication channels for feedback and make sure that we understand what's working and what's not working. Some of the common integration barriers that are reported frequently include costs. Again, the procurement costs and startup costs, the time, the clinic flow. Is there a heavy distance to travel, so that affects demand? Is there fear of additional follow-up, and does that affect demand? So working with both clients and providers to understand barriers better can help programs mitigate some of these as much as possible to provide high quality services and client experience, and a better client experience. Next slide. I think this is my last slide, but speaking of client experience, really no service delivery program is complete without robust and thoughtful monitoring and evaluation plans, and this includes M&E from different program angles. M&E is an important factor in all of the work that PSI supports, but we have to acknowledge, I think, that integrated programs can be more complex to monitor. So we want to make sure that we keep an eye on our program outcomes, so routine program data collection and reporting as usual, making sure we're paying attention to quality. Has quality of services changed since we started integration? Are we able to ensure through supportive supervision visits that quality stays high, and we need to make sure we pay attention to those outcomes. We also need to be cognizant of what clients are experiencing and taking away from those experiences, and there are a variety of ways to measure this. And as I mentioned in the previous slide, we need to pay attention to providers and how they're being supported to offer integrating services. Getting service data at the client level has been challenging. It's the best, but it can be hard to do. But some of the development of some digital platforms and the electronic medical records, or EMRs, are helping to reduce some of these barriers. And on a final note, I wanted to mention our role as the operational research lead in the PEER program in Mozambique, and why the relevance to M&E. This is exciting for us because we'll have the opportunity to systematically evaluate and improve multiple service delivery models through this program to improve family planning and cervical cancer care for women. I think we have to be frank that we don't have all of the answers. I think we're trying to build the evidence base and develop best practices, but there are still gaps. And so we need to continue to study and monitor to fill some of these gaps and figure out the best way forward. So with that, I'll pass it on to the next speaker. Thanks very much.
Thank you so much, Eva. You raised a number of really important issues around listening to the clients, around national policies and guidelines, around same-day screening and treatment, and the importance of integrating those. So thanks so much. I'm going to move on now to our next speaker, which is who's Kevin Piney. He's the biomedical R&D team lead in the Research, Technology, and Utilization Division of the Office of Population and Reproductive Health at USAID. In this role, he manages a portfolio that includes contraceptive research and development activities, as well as the agency's non-PEPFAR funded cervical cancer portfolio. Kevin has a PhD in molecular, cellular, and developmental biology. Kevin's topic is evaluating the evidence base for family planning and cervical cancer prevention integration, the PEER program. I think we're all really excited about this new prevention program and looking forward to hearing more from Kevin. So take it away.
Great, thanks, Selena. And I just want to start out by thanking the other two speakers that came before me. I think we'll get into the programs that we're supporting here in the next few minutes, but you know, I think the Bill and Melinda Gates Foundation funded work that both your programs implemented was really a major inspiration for how we designed our programs. So next slide, please. So I'm really excited to see that the area of family planning integration with cervical cancer screening is seeing such a sort of increasing interest. USAID has a long history in supporting voluntary family planning programming. For over 50 years, we've been helping countries meet family planning and reproductive health needs. And the investments overall have spanned from a range of activities from commodity procurement to service delivery, working on some of the underlying policy and communications frameworks that lead to strong programs. And importantly, I think it's also, I think, critical for this area that we have a long history in supporting research and R&D as well. So for over 40 years, we've played a significant role in advancing global investments on family planning. And it's, I think, really important to highlight, too, that in some way, shape, or form, USAID has contributed to the development of nearly every contraceptive method on the market today. And it's really, I think important that the office has played an important role in this area as well, because as we sort of advance some of these R&D goals along the pipeline to service delivery, it's been really a privilege to see the products roll out in countries. And I think in 2019 we've had over 24 million women and couples reached with contraceptive services and supplies. So next slide, please. But as many of you know, the investments that USAID has in global health programming are not exclusively for family planning. We have long-standing country support and programming in infectious disease, TB, neglected tropical diseases, malaria, HIV, and a host of other health areas. And as we continue to be active in supporting the programs that help women and families thrive, we know all too often that women's lives that are saved with other investments are taken too early by cervical cancer. So I think our experience with handling infectious diseases and women's health areas highlights our sort of unique placement to help work within the cervical cancer space. So in the past couple of years, we've been looking at ways that we can advance our support of cervical cancer programs more effectively, and also ways that we might be able to integrate within the health areas that we're currently investing in. So next slide. And I think right around the time that USAID started to explore areas that we could work in the cervical cancer space, there was a global call to action by WHO to eliminate cervical cancer as a public health threat. And I think that this global push happened at a really interesting time, because it started galvanizing a whole host of other donors, NGOs, and the broader global community to look at new and improved ways of eliminating cervical cancer. So while there are a number of partners listed here as part of the WHO call, it's important to note that there are dozens of other partners working to eliminate cervical cancer as a public health threat. And the agency is continuing to work closely with both WHO on their strategy for elimination, but also looking at ways that we can work with other organizations whose programming might benefit from USAID's technical expertise and comparative advantage within the global effort of elimination. Next slide, please. This slide, I think, is a pretty important slide from WHO, illustrating nicely the rationale behind both supporting vaccine as well as screening and treatment programs in order to sort of bend the curve of elimination closer to where we are now instead of looking out beyond the year 2100. So as we can see with the current trend of vaccination and screening, elimination is not on the horizon. But if we can really ramp up intensive vaccination campaigns as well as screening and treatment campaigns, we can start bending the curve, and the potential to potentially reach elimination starts to grow closer to 2060. So USAID has, for a while now, had a long sort of general contribution to the Gavi Fund, who's working, on increasing access to vaccination, but with the access issues and stocking issues, we've seen that vaccination has actually become quite hard for low and middle income countries to achieve. And I think as the vaccination campaigns move forward, it's still really critical that we set up intensive screening and treatment campaigns to reach the women that have not been reached by vaccination. So our programs that we'll be sort of talking about today are focusing more on the screening and treatment side. And I think, as I noted at the top of the talk, the MSI and PSI work that was funded by the Gates Foundation was I think quite innovative and something that we tried to model our programs off of closely. And I think, as they sort of highlighted, they were using cryotherapy and other visual inspection screening techniques. And we wanted to figure out a way that we could take some of the language coming out of WHO, sort of endorsing higher precision screening techniques and thermoablation, and build it in within an integration framework. Next slide, please. So we looked at two countries that we wanted to pilot this work in, both Malawi and Mozambique, who are priority countries for our family planning program, but also two countries with a really high rate of cervical cancer incidence. And the first thing that we wanted to look at was how can we scale up models of integrated service delivery with voluntary family planning and cervical cancer screening. But we also wanted to know whether or not increasing those two services would impact both the quality and the uptake of either. And I think, as I mentioned, we're really focusing on thermoablation and HPV screening, but both of those technologies are quite new, and there are some costs with those. So thinking through Objective 2 on ways that we can both support the development and introduction of new technologies that might lower the costs and increase access to some of these higher precision tests. And we're taking an approach where the majority of the budget will be for service delivery and reaching clients and screening women through integrated platforms, but also 30% of the budget will look at sort of embedded implementation research to look at cost effectiveness and analyzing our treatment algorithms and ensuring that some of the data that we're generating within these service delivery platforms is able to be disseminated to partner countries. Next slide, please. So we decided to support this work through the PEER program, which is within the Global Development Lab at USAID. And PEER is a competitive awards program that partners US-based research institutions with researchers and scientists within developing countries. And I think that's really important for this program because the ability to partner U.S. researchers with in-country partners will, I think, lead to more rapid dissemination and uptake of findings within the partner countries, as well as linking it to the global community so that the evidence can be integrated within global level policies in a more rapid manner. The investments that USAID are making are really not intended to replace country-led investments. Rather, we're trying to really generate evidence that can influence the global and in-country policymakers so that they can basically use evidence to best inform how to allocate limited resources in order to maximize service delivery and reach. Next slide, please. So as I mentioned, we're working in both Malawi and Mozambique, and we're really excited that in Malawi we're working with the University of North Carolina at Chapel Hill, as well as the University of North Carolina in Lilongwe. And then our in-country PI is actually located at the University of Malawi College of Medicine. We're working closely with the service delivery partner, MSH, and other partners to be able to do both the monitoring and evaluation through Malawi Polytechnic and some of the cost effectiveness studies through the University of Washington. And here we're really looking at two different service delivery models to increase the uptake of cervical cancer screening and family planning. We're using both a static site and a mobile outreach approach. And we're looking at whether or not the static sites or the mobile outreach approaches change access or uptake to the services. And we're doing that through sort of a randomization process where we're comparing similar clinics in one district with a similar clinic in another district to try to see if there's variation in public and private sector sites as well as some mission hospitals. And in both projects, we're actually using self-collection of cervical swabs for HPV testing, and women will undergo a visual assessment for treatment, and women with a lesion will receive thermocoagulation. And I think, we're really excited about this new approach to sort of service delivery using HPV testing, but as the other two speakers mentioned, the client load analysis is pretty important. And when we think about this, the exciting thing is if only 20% of women are infected with HPV, you reduce the amount of pelvic exams you need to do by 80%. But we really also need to be cognizant that sort of all of that additional burden is now shifted onto the laboratory staff and the capacity at the labs to be able to run the gene experts. So while we may be reducing client load on providers, we may be increasing client load on laboratory technicians and infrastructure. So I think it's really important to look across the whole service delivery experience when you're thinking through client loads. Next slide, please. And just to sort of highlight the Mozambique work, I know PSI highlighted it a bit on the last presentation, but they're also looking at ways to integrate service delivery, but within this award, we're also looking at point-of-care HPV tests, as well as other imaging systems that might provide a lower cost alternative to Gene Expert, and thinking through ways that, as WHO makes recommendations to increase access to higher precision tests, and we start to develop evidence on how to make those tests accessible within countries, we have to think about innovative ways to start driving down the cost of tests per woman. So the last slide, I'll just highlight a few of the other things that we're working on within the global effort. I mentioned we're working closely with WHO on the strategy for elimination and working on the working groups for the components of that. We're also working closely with a whole host of interagency partners. Of course, we recognize that the National Cancer Institute, CDC, PEPFAR, all those organizations have been working in cervical cancer a lot longer than USAID, and we're trying to collaborate with them to determine how best we can integrate within the whole of government approach for addressing cervical cancer. I talked about our sort of investment to the general contribution to Gavi, which in part supports some of their efforts on HPV vaccination. But we're also using our sort of staff expertise to think through technical assistance to countries and integration activities, but also ways that we can provide global technical leadership through publications and through working with organizations that are trying to introduce new methods and helping them think through market shaping and other sort of important components when going through the process of introducing new technologies. So I think I'll end there, but I just want to thank everyone again for joining and for the other two speakers for sort of providing the wealth of evidence that they were able to, and looking forward to seeing the integration space flourish as we move forward. So.
Thanks so much, Kevin. It was really interesting and exciting to hear about the really high quality research and implementation underway in Malawi and Mozambique. I want to start during a few minutes of Q&A. We don't have a lot of time. We might run over by a minute or two just to ask a few questions. And again, if you want to ask questions in the Q&A box, that would be great. I want to maybe take the chair's prerogative and ask all of you a question, which I think all three of you have raised, which is about the sort of challenge of expecting family planning providers to add in cervical cancer screening to their workload. We know they're all pretty busy already. And I wonder if you have sort of experiences and also ideas on how we can make it easier and more acceptable for these family planning providers to add in cervical cancer screening. So I'll throw it out to each of you and let you jump in. Ravina, do you want to start?
Yep, happy to start. It's a really good question, Selena, and it was a recurring theme in our in the focus group discussions that we had with our providers. That suddenly the client load was increasing. We were expecting them to do a lot more. So I think firstly, I think even though family planning providers were concerned about their workloads, there were several who in the course of this work came up to me and said, I've been inserting IUDs for 30 years and I was really bored doing this. So this has helped me to gain a new skill, and I'm really excited about being able to do this. And I see people in my community dying from cervical cancer, so it means a lot to me that I can help towards this effort. So that was one great insight from a family planning provider. So in the as we implemented, we tried to, I think the first important thing is to triage really well. Now, a service provider is not required for all parts of the client journey. As soon as they enter the facility or the outreach camp or wherever it is that the service is being provided, you start, where can we reduce the burden on the service provider? What can our counselors, we even use our drivers to do some counseling. So, how can we task shift so that we reduce the burden on service providers? And secondly, if they are if there is going to be this increased burden, let's say on outreach, then, do we need just assessing what is the number of service providers required? So, just adding one extra service provider in a particular setting completely transforms the way the program is implemented, both in terms of how the service provider feels about it and also in the quality of the service that the client receives. So anyway, those are my thoughts on that, Selena. I'll hand over to the other speakers.
Thank you. Eva?
Hi, thanks for the question. I think it's a really, really complicated one, but a critical one to think about in the early stages. So starting, and I'll qualify this by saying I certainly don't have a magic bullet on how to, make sure providers are happy with the integration, but I think what we need to do is start with providers. So before service delivery integration starts, I think doing a good understanding with a group of providers and understanding, I think, one, how they value each service. So how do they value family planning services? How do they value cervical cancer programming from a public health perspective, a personal perspective, to understand if they don't think it's important and we've added a second service that they don't think is important, it's never going to work. And so how do we get there to make sure we're all on the same page about the value of these preventative services. The second thing I would do with providers is, from their perspective, how would this work best in terms of efficiency and in terms of provider satisfaction? What's their comfort zone in terms of the numbers of women they could see, the process by which they see them, what's right outside their comfort zone that they would be willing to tolerate, what's way beyond what would be tolerable, what would ensure job satisfaction. So I think those sorts of things would need to be explored. And then from a task shifting perspective, as Ravina mentioned, I think that's where we integrate the client perspective and get client feedback on what sort of task shifting is acceptable, what, for example, information would be acceptable to receive as a group or from a person who's not the actual procedure provider, what wouldn't be. So exploring some of those ways to build efficiency, I think, would be a good start.
Great. Eva, before I move on to Kevin, just a quick question that came in. People wanted to know if PSI is still using cryotherapy for treatment of cervical precancer.
Yes. So I think it reads as cervix cancer treatment. I think you meant the pre-cervical lesions.
Yes.
Yeah.
Okay, great. Are you moving towards thermal ablation as well?
Yeah, I think everybody's really excited about the thermal ablation, and that's the direction where we would like to go. I think there's some things to sort out in terms of procurement and training and things like that, but it will be infinitely less burdensome than cryo. So we're looking forward to being able to do that.
Great, thanks. Kevin, could I turn over to you?
Yeah, I think the other two speakers addressed it quite well. So I don't know if there are other questions, since we're short on time, that might be more useful to answer.
Sure. One question as well is, do you think new technologies that we've been talking about are going to make this easier to do family planning and cervical cancer integration?
Yeah, absolutely. I think, one of the things that we're thinking through is, with GeneXpert, although it's a really good platform for HPV detection, it takes a while to run the samples, and not a lot of samples can be run simultaneously. So when you're thinking through sort of mobile outreach and even large volume static sites, the HPV testing might make single visit approaches harder to sort of pursue. So I think when we're thinking about trying to go into larger volume family planning clinics and working through community health workers that are bringing women contraceptives, if we can start to think through ways to get paper-based tests that can be run within an hour at a very low cost without the need for laboratory equipment or specialized training, I really think that we could start linking women to care much more quickly. So there are plenty of other examples of how we can sort of use technology to make visits more, less time consuming for both clients and providers. And so we're trying to think through how we can best support that.
Great, thanks. Well, we've come to the end of our time. If you do have a question that hasn't been answered, you can email us at info@togetherforhealth.org, and we'll try to get an answer for you from the speaker you're most interested in hearing from. I really wanted to thank everyone for joining us on this webinar on family planning on cervical cancer integration, and especially thank our speakers for their excellent presentations. We are going to be posting the presentations on our website, togetherforhealth.org, within the next week. So you can share the presentations or watch it again. We really appreciate it. I also wanted to call your attention to the fact that we will be starting a new webinar, a spring webinar series in February. We're in the process of getting those set up. So if you have any suggestions of topics that you would like to hear about related to cervical cancer, please feel free to send us an email. I'd like to really thank you for participating and thank our speakers, and enjoy the rest of your day. Thank you.